My patient safety goal today that we're working on is medication safety, focusing specifically on improving the education when medication changes to improve the compliance after like a hospital or clinic encounter, communicating to those home health nurses when applicable, and getting the follow-up with clients to ensure that they fully understand. Nursing patient safety goal 3601 is using medication safely. I'm going to focus on the impact of medication changes and compliances with elderly patients who are living independently, whether they have or don't have home health care. Medication changes, either dose increase, new medications, discontinuing, or changing how patients take medications, can be challenging to correctly implement. Education, communication, and follow-up are essential to ensure that the interventions made with medication changes are successful. Oftentimes, I will see meds changed in the hospital. Patient doesn't quite understand why they got changed. They don't really worry about it for another week or so. I come along and see that they haven't actually been doing it, which means the intervention the provider placed didn't even have a chance to be effective. So I'm focusing on reducing some of those barriers. Why is this where my focus was? Kind of like I said before, but I see it all the time. I do a little bit of home health. My clients are in the hospital, typically a CHF exacerbation, UTI, pneumonia, you name it. Medications are changed. The patient is discharged home with a list of changed medications. The nurse went through, she highlighted it, she wrote heart med on there. She, please finish, pick these up at your pharmacy. But the patient doesn't understand it, and therefore these changes aren't always implemented. Uncompleted antibiotic courses, increased diuretic schedules are not followed. All of these and many more things lead to increased complications and a higher risk for readmission. We know that hospitals don't like a 30-day readmissions, yet 40% of the 30-day readmissions in patients over 65 can be attributed to medication changes and errors. We know that patients with multiple comorbidities or those who have a poor support system are at a higher risk for readmission. It's also worth noting that no one changes their medications because everything's going good. Therefore, the medication education is being given to someone who really isn't at the top of their game. They're sick, they're run down, they're not feeling well, and we're implementing brand new information expecting them to understand it and do it effectively. The way medication changes are communicated are essential. We need to take the time to ensure that patients understand and then can explain it back to you as well. So the literature review. What does everyone tell us in all the research they've done? Patients want and need to be involved. Patients who had discussions with their providers about medication changes were more likely to administer safely and correctly at home than those who reported that their provider told them what changes were being made without taking time to have input or feedback from the patient. We need to involve home health, public health, senior meals. Call that pharmacy to see who usually picks up their meds. If an elderly patient with a UTI, they're not going to give you the most accurate information. Call the pharmacy. They might say that actually no, her niece picks them up and she sets her meds up for them. Well, then you want to make sure that that niece is contacted to know that there's a new medication, assuming she's on the emergency contacts, and okay to give information to. If possible, bring a loved one or trusted caregiver in. If that patient has a home health service, make sure that there's a discussion with those healthcare providers. They can often give valuable insight. I talked about this a little bit in the last slide, but patients want to have input and they want to be involved in their care. They also want to know their rationale. Think if you give the why, they'll comply. Patients have stated in different studies that when they understood why they were taking different medications, why it was increased, they made sure they were taking it. If a patient understands that you're increasing their furosemide, but you say, hey, this is your water pill, your legs are swollen, we need to increase this a little bit, that's kind of why you're having a hard time breathing, they're a lot more likely to comply with it. Assess the current healthcare literacy and then meet them where they're at. Another big tip I can see is adding that medication purpose, what it's for, onto the bottle. I have seen providers do it where you just put fluid for water retention, for your heart, on different meds so that they can associate the medication with the condition that they have. So what's the big plan? I believe we should implement a transitional care nurse role. This would be a multi-agency role. This nurse would work with clients who are seen and identified as high risk with multiple comorbidities, complex medication regimens, acute illness, independent living with limited support. All these people could have a referral placed to the transitional care nurse. In a hospital setting, ideally that nurse would also be part of the discharge planning so that she was fully aware, he or she was fully aware of the goals that were being set out. In a clinic setting, when there's medication changes, the TC nurse could be contacted to do at-home follow-up and make sure that everything's going well, the changes are being implemented correctly. The nurse could see the client a few times, ensuring that they understood their medication regimen, continue the med ed now that they're feeling better and a little bit more able to comprehend that information, ensure that those follow-up appointments are being allowed, as well as being really versed in the community resources. Take a peek around if food assistance needed, if there's issues with transportation, if in-home therapy, that nurse could coordinate those things. I'm going to use the Institute for Health Improvement model. It asks 3 basic questions. What are we trying to accomplish? Ultimately, to improve medication safety and compliance. A lot of times when we're not complying, we're not intentionally being unsafe, but that's what happens. A result of improving those things would be decreased rehospitalization and increased patient quality of life. No one wants to spend time in the hospital. How are we going to measure whether that's worked? We're going to go through the follow-up appointments and look and see on those follow-up, are our labs showing our patients reporting that they have taken their meds correctly. We're also able to take a peek at the hospital's readmission rates. Are they lower? Is there less people coming back within that 30-day window? What changes can we make to result in this improvement? I believe that implementing the transitional care nurse as kind of a guide back into the home setting would greatly improve things. The biggest part, obviously, of implementation would be finding the right nurse. This nurse needs to be driven, able to work autonomously, community-minded, aware of all current resources, able to establish collaborations with various healthcare teams. We know that we would need to have open communication with all the clinics, with the pharmacies, with the hospital, with our therapy teams and our home health as well. We also know that the way we talk to people is really important. From a healthcare standpoint, we've all heard of motivational interviewing. So providing that training or refreshing courses to medical providers or nurses would empower them to involve the patients in their own care, which impacts their ability to understand. Medication education being done in a way that the patient is best able to understand and have input will improve our outcomes. This is all great in theory, but what's going to stop it? What are the barriers? Funding is the elephant in every room these days that no one wants to talk about. Who pays for this great program? As an upstream approach, it would take some time to see the fruits of our labor, which means larger companies, our big hospitals, they're going to require some of that solid data to show the rates of rehospitalization are decreasing. Medicare is a large funding source for hospitals, and we all know that they penalize hospitals with higher than average readmission rates. Money talks. This is going to be a big motivating factor for hospitals to want to fund part of this program. I believe ideally it would be a split funding program. There's also grant funding available for prevention and health promotions from Health and Human Services with goals that patients are able to live in their homes as long as possible. I believe there is ways to utilize this funding to create a program like this. I also think the biggest thing is word of mouth. We need people to know that it's a really good idea. That's also going to decrease our reluctance. A lot of patients don't want to have a nurse come into their house. They feel like it's an invasion of privacy. So just kind of establishing who you are and what your goals are will be really helpful. The other barrier is going to be the rural location specifically that I'm in, because sometimes you're going to have 6 patients discharged in one day and sometimes you're going to have 1 in a week. That I think will start to flow out as the word gets out of what this role is, because then anyone that's going to that clinic is going to have a quick touch base check-in, and that will create a little bit more consistency in time and hours for that nurse. The biggest part of this team is the community. This project is to keep our community healthy. We need the pharmacy on board to help with med changes that haven't been flagged by a clinic or hospital. They see something coming through and they're thinking, I'm not sure if the patient's going to be able to handle this. Having them being able to give us a call would be fantastic. Clinic and hospitals are going to be the main source of referrals, so they need to understand fully what that TC nurse visit entails and the benefit it would be to a patient. Home health, Meals on Wheels, senior services, senior transport, they all need to be aware of who we are and work closely. Organizationally, they're going to need to have input, feedback, and funding from the hospitals, health and human services, and clinics. Therefore, it's important to keep them involved in our program. As a BSN, what's our role in this situation? Set it up, right? We're kind of the mind behind it all. Evaluate the current outcomes and medication compliance. Look at where we're at. You don't know where you're going unless you know where you're coming from. Collect the data on home medication safety. Look right now when we're coming through those post-visit notes, how many patients are actually taking their medications correctly. Collaborate with your team. Look at all the resources you have and create a really good quality improvement plan. After the implementation, we're going to need to evaluate our efforts. So all of this, and did it help? What did we do? First and foremost, money talks. So during the implementation period, did we see a decrease in hospital readmissions related to medication changes? This will be the big ticket that will help with sustainable funding from private healthcare organizations. Talking to those who have utilized the program and their families will highlight the impact it made. Patient statements need to be documented. Show those to your stakeholders. Show those personal stories along with the numbers. That's how we're going to get a program like this to be sustainable. Ultimately, we want to be supporting our patients. We want our patients to have improved medication safety. Then we'll see patients who are able to remain in their homes, avoid hospitalization, and experience an improved quality of life. This program will reduce healthcare costs long-term as it stays in play with less readmissions, with patients who are having things evaluated sooner. Those clinic appointments are having the full follow-up that they need and not resulting in hospital time. Here's a list of my resources, and thank you very much for listening.